The first one was on COVID neurological changes, hosted by Chairperson, our president for the Neuroclubwebinar. And so this second one here now, today, we are very glad to have all of you here. It is not an everyday affair that we get otologists, neurologists, neuroradiologists, radiographers, MR physicists, and basically the whole community to Zoom in together. We are very glad for everybody's time. The focus for this hour's webinar will be on sensory neural hearing loss and vertigo neuroimaging. And without further ado, this is the schedule for this hour. The first person presenting will be Harold from Tan Tock Seng Hospital, Diagnostic Imaging. He will be going through the findings from his papers that was published earlier this year in February at the Annals Academy of Medicine. So Harold, go ahead.
Ling, you need to stop sharing screen because we can't share.
Okay. Yeah, okay.
Okay, hang on.
Yep.
Just give me a sec. Stop the share first. Let's get back to this. Put this on here. Okay. Okay, can you all see it?
Yes, yes.
Okay, all right. Harold, we'll start now.
Okay, good afternoon, everyone. So the topic that I'm giving my talk on is on differential diagnosis of vestibular ganglion from intracanalicular schwannoma on screening non-contrast MRI. So the original article that this is based on is from this journal article, which was recently published in Annals Academy of Medicine, Singapore. So just to start with the vestibular ganglion, also known as the Scarpa's ganglion. This is a ganglion which is originating from the vestibular division of the 8th cranial nerve. It is located within the internal auditory canal. And it contains the cell bodies of bipolar primary neurons, both in the superior division and the inferior division, as shown here. So these can result in focal enlargement along the vestibular division and can mimic small lesions on imaging. A little bit on vestibular schwannomas. As we know, these can present with sensory neural hearing loss, among other symptoms and signs, and also arises from the vestibular division of the 8th cranial nerve. It's been found that it most commonly originates from the vestibular ganglion itself. So small schwannomas that may occur in this region can share similar imaging findings as vestibular ganglia. So there's a need for accurate imaging diagnosis to differentiate the two. The current practice that is employed at Tan Tock Seng, as well as in Changi General Hospital, is that patients are screened with a single sequence, non-contrast enhanced MRI, utilizing high-resolution T2 weighted imaging to exclude any masses in the IAC as well as the cerebellopontine angle. If a lesion is detected, then a so-called full MRI study is employed, which also includes the high-resolution T2 weighted imaging, as well as pre- and post-contrast T1 weighted imaging. So this full MRI study is considered the current gold standard for diagnosis of schwannomas. However, compared with the screening study, of course, it requires additional scanning time, which leads to increased cost and exposure to intravenous contrast material on part of patients, which may be an issue in some who have underlying comorbidities. So with continual and incremental improvements over the years in hardware and software, this has led to increased spatial resolution in the images. And now schwannomas as small as 2 millimeters can be detected by MRI. However, these small vestibular ganglia are also often detected on single sequence non-contrast MRI studies. And so accurate differentiation is necessary or can be difficult on screening. The aim of this study was to identify any imaging features which would differentiate vestibular ganglia from small intracanalicular schwannoma on the single sequence non-contrast MRI in order to eventually reduce usage of the contrast enhanced T1 weighted studies. It should be noted that at this point, other causes of sensorineural hearing loss would have already been clinically assessed and further investigated by other means by the otolaryngologist, such as labyrinthitis and Meniere's disease. So what would be the rationale for this study? Why not continue the current practice as is? So there's an ever-increasing emphasis on maintaining reasonable healthcare costs, as well as efficient utilization of resources in terms of time and equipment and manpower and so forth. There's also a substantially low incidence of vestibular schwannomas diagnosed in patients, about 4%. So there's a question whether subjecting many patients to identify such a small proportion is necessary.
You cannot see the player when you're something.
So moving on to methodology, this was a retrospective study which was carried out which looked at patients from May 2012 to April 2017. So 169 patients with IAC lesions who were selected, who had a single sequence non-contrast MRI study done, as well as a subsequent contrast enhanced T1 weighted MRI imaging study. The exclusion factors are listed as follows. It's worth noting that any unequivocal diagnosis of vestibular schwannoma on the single sequence MRI, these were also excluded. So in total, 90 patients with 102 IAC lesions were found. In terms of the imaging protocols used, for the single sequence non-contrast MRI, this consisted of axial T2 weighted imaging acquired for all patients. This consisted of 3D isotropic high resolution images, allowing for multi-planar reconstructions after acquisition as well. So this could be useful for identifying anatomical structures such as the superior and inferior divisions of the vestibular nerve. And this was performed with various MRI scanners, 1.5 and 3 Tesla, by select manufacturers. The post-contrast MRI studies were used for definitive diagnosis of the lesions, and the IV contrast media, DOTA-REM, Gadovist, were employed. In terms of interpretation of the imaging, the IAC lesions were reviewed by 2 radiologists specializing in head and neck imaging. So on the contrast enhanced studies, those lesions which demonstrated enhancement were diagnosed as schwannomas. And if there was no enhancement seen, then this was considered as vestibular ganglia. So the measurements were performed on the axial plane in the T2 weighted images. And the following parameters are listed. So the length along the vestibular nerve, the width perpendicular to it, the distance from the IAC fundus to the closest margin of the lesion. And so these were measured. And then the length and width ratios for all lesions were also calculated. So statistical analysis was employed for all of these parameters to compare the ganglia and the schwannoma. And it was found that the distance from the fundus was not so statistically significant, but the length width and the length width ratio were. So taking these parameters and analyzing them further, the ROC curves were constructed and the area under the curve also calculated. And it seemed that the width had the best trade-offs in terms of sensitivity versus specificity. So as the aim of the single sequence MRI studies was to exclude as many vestibular schwannomas as possible and to diagnose vestibular ganglia, the cutoff values of all the parameters were determined for firstly highest specificity, then by sensitivity. And the cutoff values are listed as follows. So for length, less than 1.9 millimeters, for width, less than 1.3 millimeters, and for the length width ratio, more than 2.3. So just going through this, as an example, by applying the cutoff for the width, less than 1.3 millimeters, it was found that all actual schwannomas were excluded, giving a specificity of 100%. And a sensitivity of 97%. So just 2 vestibular ganglia would have been diagnosed as schwannomas due to their larger widths. And the overall accuracy was 98%. And so these calculations were also performed for length and ratio of the length and width. So this is a summary of the imaging features. So for vestibular ganglia, it was seen to occur most commonly in the inferior division of the vestibular nerve, 76%. Whereas for intracanalicular schwannomas, oftentimes they were too large to determine where exactly they arose from. But they were seen to be slightly more common in the inferior division for the ones that were able to be traced. Mostly in the vestibular ganglia, they presented as small nodules, whereas the schwannomas tended towards a larger size. The ganglia were more fusiform in shape, as noted by the length-width ratio of 1.8, whereas the schwannomas seemed to be more rounded in shape with a length-width ratio of 1.5. And further, the vestibular ganglia, oftentimes the patients presented with ganglia on both sides. And when they did, they were largely symmetrical in size and appearance. Whereas for schwannomas, none of the patients studied showed any bilateral lesions. So in summary of the diagnostic performance, using a width cutoff of less than 1.3 for diagnosing an AIC nodule resulted in increased confidence in diagnosing vestibular ganglia. And as I've explained before, the sensitivity was 97% and the specificity was 100% for using this particular cutoff. If the cutoff was applied to the study population, then just over half of the contrast-enhanced T1 weighted imaging studies would have been avoided. There are some limitations to the study, one being that the pathological diagnosis was available only for a small number of cases. It is because most of the diagnoses are based on the gold standard, current gold standard of contrast-enhanced MRIs. And this is actually reflective of the current clinical practice. And so only lesions which were seen to cause significant symptoms underwent surgery and histological evaluation. There was a selection bias noted in that only the vestibular ganglia that were large enough to be detected on both the single sequence MRI and the contrast-enhanced MRI studies were included in the study. So the vestibular ganglia that were seen in this particular study tended to be on the larger side. And then lastly, different scanners and imaging protocols were used, which resulted in different spatial resolutions, although they were all still high resolution. And the protocols were standardized and were reflective of the nature of the routine practice. So in conclusion, the IAC nodules, which are seen in single sequence non-contrast MRI, which are small in size, less than 1.3 millimeters, fusiform in shape with a length-width ratio of 1.8. Those which are bilateral and symmetrical are more likely to be vestibular ganglia rather than vestibular schwannomas. So in practice, this could potentially be helpful in reducing the need for subsequent assessment with contrast-enhanced T1-weighted imaging studies. And this could result in a substantial cost savings for patients. So it was noted that for contrast-enhanced T1-weighted imaging, this can lead to costs of up to $1,220 for patients. So so this can reduce the need for subsequent assessment unless there is a further clinical deterioration in the patients with respect to the symptoms on the ipsilateral side. Okay. And that concludes my talk. Thank you.
Thank you very much, Harold, for the very interesting sharing. This is very pertinent for us in radiological practice because of the frequent use of this screening protocol nowadays to save costs, save on logistics and contrast. Just wondering, though, for the clinicians who are signed in, maybe some of you all might have some comments. How would you all feel about it if the radiologist is confident and does not go on to a contrast examination based on the findings that's been shared in this paper? Would some of the clinicians feel that you know that they will be, you know, they would still prefer a contrast follow-up just to be very, very sure about this? Or would they be also comfortable if the radiologist is confident based on such findings shared in this paper to just either watch or just totally dismiss and not follow up anymore? Would there be any comments from any otologists or clinicians amongst those signed in? Or any radiologists even too?
Hi, Ling, Vanessa here.
Hi.
Yeah, thanks for inviting us. It's a really interesting paper. And I saw such a case when I was on observership in Melbourne, and yeah, similarly, the clinician was wondering whether it was something of concern. Yeah, so I think personally, I would look at a few factors like the patient's age. If it's a very elderly patient, I probably will just reassure the patient and won't want further imaging, and just discharge the patient. If it's a younger patient and asymptomatic, I'll probably do the same thing. So I think it really depends on the patient's symptoms as well, whether I will move on to a contrasted scan.
Okay, anybody else has any other comments? Actually, my another thought that occurs to me is that do you think there might be any medical legal issues if we choose to just watch? I mean, the rate of growth probably is not very high if indeed in the end this turns out to be actually a schwannoma, right, as well. So whether you feel that there could be any medical issues as well? Would there be any views from any clinicians or any other radiologists around? I guess I think maybe one of the ways is if we don't move on to a contrast scan, at least do maybe follow up just to document stability. Yeah. So if nobody else has any other comments on
Ling, I'll just add that
yes,
here in Tock Seng, the otology section would, if the patient has some symptoms, but it looks like it's probably just going to be a ganglion rather than a schwannoma, they will do follow up for a period of time they would still use this screening study, and they'll try to document whether there's any progression in size.
Okay,
Initially, they would just do contrast enhanced studies when we suggested the contrast enhanced studies. But they themselves were also feeling that, hey, you know, these are often just going to be ganglia, and we may be overdoing, we may be going a bit overboard here. So now they tend to just follow up with sequential MRI. Of course, if there's a change in clinical symptoms, they will do the necessary.
Hi, Clement here. The question for Julian. The paper document any appearances of this vestibular ganglion in terms of whether some of them could be cystic appearance on the T2 weighted images, or were they all diffusely hypointense on the high resolution T2 images?
They were all hypointense. We had no ganglia which had a cystic appearance.
Okay, thank you.
Okay, if there are no other comments, in the interest of time, we're going to move to the next section, which is a presentation by Siwei from SGH. She will gallop through the recent imaging changes. Yeah, the Meniere's imaging. Please go ahead, Siwei.
Hi, Ling. Can I just trouble you for a while? Can you see the arrow?
Yes, we can.
Okay, great.
Welcome to Gallop's Meniere Imaging. I am Dr. Kheok and I am a consultant radiologist in the Department of Diagnostic Radiology in Singapore General Hospital. These are the topics for this short presentation, including an introduction to Meniere's disease, evolution of MR imaging techniques, grading systems, significance of radiological findings, and clinical impact. Treatises on the diagnosis and treatment of vertigo can be found in the writings of ancient Egyptian and Greek physicians. Vertigo was lumped together with epileptic seizures and strokes under the rubric of apoplectiform cerebral congestion, a condition thought to result from the overfilling of blood vessels in the brain. Treatment consisted of bleeding, leaching, cupping, and purging, a regimen that required a hardy constitution. In 1861, Prosper Meniere described a series of patients with hearing loss and episodic vertigo before the French Academy of Medicine. He linked the condition to inner ear damage. Meniere's disease is a clinical diagnosis. It is divided into two categories: definite and probable Meniere's disease, as defined in the table shown. Apart from sensorineural hearing loss and episodic vertigo, patients can experience tinnitus and fullness of the affected ear. Endolymphatic eye drops is a hallmark of Meniere's disease, which has a complex etiology that is likely multifactorial. There is propensity for endolymphatic eye drops to affect the apical turn of the cochlea that can account for low-frequency sensorineural hearing loss. Eventually, there is excessive endolymph accumulating in the inner ear, causing damage to the spiral ganglion cells. This arrow points at the utricular rupture. Some pathology samples show microtears of the raceous membrane, leading to postulation that potassium-rich endolymph escapes and mixes with the perilymph. This admixture is toxic to cochlear hair cells and vestibular sensory neurons of cranial nerve 8. This is a histological sample of a normal cochlea. The perilymph is in the scala vestibuli and tympani, while endolymph is present in the scala media. In cochlear hydrops, fluid and endolymph accumulates. This is how hydrops look like in the pathology sample, with profound hydrops in the basal turn, normal to mild hydrops in the middle turn, and moderate hydrops at the apex. Likewise, there is enlargement of the endolymphatic duct in the cochlea, reversal of the saccule compared to the utricle in this patient with Meniere's disease. Development of niche MRI techniques to identify endolymphatic eye drops in the clinical setting began in 2007. Gadolinium was injected intratympanically. Imaging was performed at 1 hour, 2 hour, and 1 day late using 3T flare sequence. Contrast first appears in the scala tympani of the basal tin and vestibular perilymph. By 1 day, contrast appears in the perilymph of the whole inner ear, as shown in this image. Endolymphatic eye drops imaging was largely driven by Japanese radiologists in the early days. The technique has been further developed and adopted in hospitals internationally. Prior to this, endolymphatic eye drops was only identified in histopathological specimens and cadaveric studies. Current state-of-the-art techniques for imaging of Meniere's disease require contrast medium to be introduced into the perilymph, either via the intravenous or transtympanic routes. Initial studies were carried out via transtympanic contrast administration. The advantage of this mode is the smaller dose of diluted contrast locally introduced, reducing systemic contrast exposure. This method has a dual advantage of concurrent assessment of the feasibility of transtympanic gentamicin therapy for Meniere's disease, with regards to access to the entire membranous labeling. However, this is invasive with tympanic membrane puncture and requires additional radio-ontological coordination for imaging 12 to 24 hours later, when the contrast reaches the perilymph and the entire labrum. There are also logistical challenges with tight MR scheduling. The intravenous route is less invasive and more convenient for the patient, as MR imaging is performed only 4 hours after contrast injection. In addition, both ears are assessed simultaneously after a single intravenous injection, whereas the transtympanic route requires separate punctures where both sides are to be assessed. Contrast is important as the perilymph and scala vestibuli and tympani enhances. Due to intact endolymph blood barrier, the endolymph does not enhance. In 2010, Dr. Naganawa and team went on to evaluate the use of intravenous contrast and further refine MRI techniques that can be used with intravenous contrast to enable visualization of endolymphatic eye drops. He found that heavily T2-weighted 3-dimensional fluid attenuated inversion recovery, as shown in the bottom image, was superior to 3D flare image, shown on the top right. It is superior in depicting eye drops with intravenous contrast administration. This was followed by the development of subtracting techniques, which they termed eye drops and eye drops 2. Eye drops 1 is created by subtracting positive endolymph image from positive perilymph image. Eye drops 2 was created by subtracting the cystinogram from the positive perilymph scan. This technique was performed to clarify the boundaries of endolymphatic space from the surrounding bones, as shown in the bottom 2 images. However, eye drop subtraction techniques can suffer from misregistration, so the team tested 3D real inversion recovery sequence in the setting of intravenous contrast administration. They found that it wasn't suitable substitute to subtraction eye drops technique, and its benefits include alleviation of post-processing,
avoidance of misregistration, and it also shaves off 7 minutes of scan time. The minor disadvantage is that there is reduced contrast to noise ratio. So at least 7 different imaging grading systems are available as of today, and we are going to summarize 4 in the following slide. Other systems that are not going to be covered include the analysis of volumetry and proximity to the round window. So this is the example of the 4 different grading systems. Nagoya's scale, developed in 2008, was the first grading system described for endolymphatic hydrox imaging. Cochlear hydrox was divided into mild or significant, based on whether the area ratio of the cochlear duct to the scala vestibuli is. Vestibular hydrox is deemed mild if it occupies an area ratio between 33 and 50%. Anything more than 50% is significant. Now, Barrett grading is easier because if the hydrox fills the cochlear or the vestibule, it is simply deemed as grade 2. Surrey grade, developed in 2017, refers to the saccule-utricle ratio reversal. So the saccule is smaller than the utricle in a normal individual. If the saccule is equal or greater than the utricular size, it is deemed at least Surrey 1. If it is so dilated that it is not visible, it is graded as 2. In 2019, a 4-stage grading system was devised. It adds cochlear enhancement to the grading system and includes Surrey grade 1 and Barrett vestibule grade 1 and 2 into this particular grade. So this is the significance of the findings. Well, it was found that mild hydrox can be present in clinically asymptomatic ear, and it is of uncertain clinical significance. However, more severe endolymphatic hydrox is more specific for Meniere's disease and the symptomatic ear. Evidently, the longer the duration of Meniere's disease, the more marked the endolymphatic hydrox is too. In addition, vestibular hydrox is also a more distinctive finding in cochlear hydrox in Meniere's disease. In the rare instance where the saccule is not visualized in a patient with Meniere's disease, it has been postulated that the saccule has collapsed, ruptured, or fistulized. Perilymphatic enhancement is an important finding. Greater perilymph enhancement, likely due to the blood-labyrinth barrier breakdown, is associated with the pathological ear and the duration of the disease. Now, we move on to the clinical impact of MRI endolymphatic hydrox imaging. The American Academy of Otolaryngology and Head and Neck Surgery Foundation 1995 guideline had a criteria of certain Meniere's disease that required histopathological confirmation. This was removed in 2015, which begs the question, can MRI endolymphatic hydrox be a surrogate for pathology? As of now, imaging of endolymphatic hydrox facilitates earlier diagnosis. It is useful in evaluating patients with profound hearing loss. When functional tests such as electrocardiography and glycerol tests cannot be reliably used. Endolymphatic hydrox imaging with intratympanically administered contrast may also be used in assessing the suitability of transtympanic treatment for patients with Meniere's disease. Herein, we reviewed the evolution and clinical implementation of specialized state-of-the-art high-resolution MR techniques to identify endolymphatic hydrox in Meniere's disease. Thank you for your kind attention.
Thank you, Siwei, for the very nice gallop through the clinical aspects and the imaging aspects of Meniere's imaging. In the interest of time, without further ado, Septian Hartono, Dr. Septian Hartono is an MR physicist with NNI, and he will go through some of the MR technical aspects of Meniere's imaging with us. Septian, please.
Thanks, Dr. Chan. I'm going to share. Okay. I'm going to discuss the sequence that we are currently using in SGH to image for Meniere's disease imaging, which is the 3D real invasion recovery sequence, which was described earlier shortly by Dr. Kheok. So our sequence, our technique is based on study by Naganawa, in 2008, which who used a 3D inversion recovery turbospin echo with real reconstruction. I will talk about that shortly later. By setting the inversion time between the null point of the paralimb fluid, which contain gadolinium and hence and therefore has a shorter T1, and that of the endolimb fluid without the gadolinium and therefore longer T1. So the basic idea is to set the TI such that you will still have positive longitudinal magnetization value for the paralimbatic fluid, which has shorter T1, but a negative longitudinal magnetization to the endolimbatic fluid. And how do we do that? So what does it mean by the real reconstruction? So a basic refresher of the inversion recovery sequence. In MRI, the signal is a complex number which can be expressed by A plus BI, where A is the real part and B is the imaginary part. And usually the way we reconstruct the image is to take the magnitude, which is the square root of A square plus B square. And the way we usually use inversion recovery is to select a certain signal value of is the TSF. But another way to reconstruct the image is not only through the magnitude, but also we can take the real value. So if we use the magnitude construction value, use the real and we are taking both the positive, the dynamic range. So how we can use this particular sequence to separate the signal coming from the paralimb and the endolimb. So the way to set this up is by, in Siemens scanner, you just go to the contrast tab and then go to the dynamic tab and then just set your reconstruction to real instead of magnitude. And then how to choose your TI. So this is the follow-up study from Naganawa group, and then where he plotted the signal intensity across various TI in the paralimb and then the endolimb. So the solid lines here represent the signal intensity from the paralimb, and then the dotted lines here represent the signal coming from the endolimb. And then I flip it to the negative plane, so taking the real value, and then the key here is to take the TI where the signal from the paralimbs is already positive because it has a shorter T1 due to the presence of the gadolinium tracer, while the signal coming from the endolimb is still negative because of the longer T1. So if we take the, let's say in here, the TI is about 2.1 second, then the signal coming from the paralimb is already positive, but then the signal coming from the endolimb is still negative. But if you notice that if we are using the magnitude reconstruction, you will have the same value coming from the paralimb and the endolimb, which is both positive values. And then that's basically the whole the whole principle of the technique, which is to take the real reconstruction and then to select the TI where the paralimb is already positive while the endolimb is still negative. So this is the parameters that we use in SGH. Again, you need to optimize the TI according to your scanner. The TI that we select is 2 seconds. The most important part is you use real recon instead of magnitude recon. And this is just one example of the difference between real versus magnitude recon. In the real recon, the value of the signal coming from this particular ROI here is -24. But if you're using the magnitude recon, the value is positive, plus 26. Another part that may contribute also to the, may be helpful also is the use of 32-channel head coil, the one that we use in our institution in SGH. So could notice that the image is more homogeneous in 12-channel head coil. That's because the SNR profile in the 22-channel head coil is more heterogeneous, where the SNR gain is much higher in the periphery of the brain compared to the central of the brain. So if we look at the SNR profile from right to left across the readout direction, then you can see that the increase of the SNR in the 32-channel coil compared to the 12-channel coil is much more significant in the periphery of the brain compared to the center of the brain. So to summarize, the technique that we are currently using in SGH is the 3D real IR TSC, using real reconstruction, not magnitude reconstruction. Then we need to optimize the TI value to separate the signal of the perilymph with gadolinium, which will be positive with shorter T1, and having the endolymph without gadolinium still negative. And then we are also using 32 channel coil for higher signal gain in the periphery of the brain for the imaging of the Meniere's disease. Thank you.
Thank you, Septian. Not sure if anybody has any specific question here with regards to the technical aspects. Any pressing questions? If not, in the interest of time, we may just move on to the clinical cases and we can still ask questions later on.
Okay, I'll ask later then.
So, to begin, Julian, do you want to go ahead first to showcase yours?
You start first. Mine will take a while to come up.
Dr. Chan, which we can go first. Clement here.
Sure, please. Already, please go ahead. Yeah.
Yeah. Okay. I'll just share my content. Okay. Can you guys see the slide?
Yes, yes.
And can you see the mouse?
Yes.
Okay, great. So I guess this is a bit of a show and tell of how we are running our Meniere's cases in NUH. So we've been doing Meniere's imaging for about 3 years. We started about 2017, and we've gone through quite a few iterations of the flare settings. So early on, we started off with what Bharath used, and currently we are kind of following the settings from Shepardari, and that is using a TI of 2350. So you can see that for them, they use a cysternography sequence, which is the space 3D, just to look at the overall volume, and then followed by their IR sequence, their flare sequence, showing the black areas as the endolymph with the utricle, and then further down and anteriorly along the wall would be the saccule. So we have generally used this for, I would say, the majority of our studies at NUH, although we are kind of progressing to a bit more, I guess, more advanced, maybe not advanced, because we're actually going backwards towards the paper that was produced by Nayagawa, and the one where he used the PPI and PEI. Okay, so we'll just go through some of the more definite cases that we've seen in NUH. So the first one is Madam NCK, 45-year-old lady. So she's actually been diagnosed with Meniere's previously, and she has been well for about 5 years. And then several weeks ago, she presented with a recurrent vertigo, and which became more frequent over the last 1 week. And the last attack was a few days just before presenting to hospital. So she reported right hearing slightly decreased, and then there was otherwise no other ear symptoms. Otoscopy was normal, head thrust was normal, gait was normal, extraocular muscle movement was normal, and no nystagmus was reported. So the PTA showed a mild right low frequency hearing loss, and the clinical impression here was Meniere's. So she was started on thiazide and betahistine, betasec, and then given a bit of steroids as well. And the MRI was requested and performed about 2 weeks after the last attack. So at NUH, we pretty much run the Meniere's study on one scanner, which is the Siemens Skyra, the 3T, but we use a 16-channel head coil. We recently acquired the 32 channel, so we've just started using the 32. But most of our studies that we have are on the 16-channel one. We use about 0.2 millimoles of GAD, which is considered a double dose, and then most of the sequences are performed 4 hours after the injection of contrast. We do one sequence, which is just a pre-contrast inversion sequence just for reference. But generally, we end up with 4 sequences running about 20 minutes. So this is the space 3D, and you can see that it shows the vestibular outline very well. And this is all the fluid within the cochlea and the vestibule. So you can see that at least on this sequence, we always look for masses along the nerves and within the CP angle, just to rule out other causes before we diagnose Meniere's. And then this is followed by the what we call the 235 inversion, the TI of 2350. And this is the post-contrast sequence. And you can see that the contrast has gone into the vestibular space. And then the black areas are seen here. So for this one, I think she was graded as definite Meniere's. And you can see that the outline here, the morphology of the utricle and the saccule inferiorly is enlarged compared to the left. But when we calculated the error, this was about 41%. So generally, we would set a cutoff closer to about 50% before we call it positive. And then we find that it's often quite hard to comment on the cochlear eye drops. So for most of the studies, we just comment on the vestibular ones. For this study, we also tried doing the lower IR, which was recommended by the app specialist. This is the TI of 1,500. And you can see that there's a difference between the bone, which is grayed out, and the water fluid, and then the soft tissue. But we've never really managed to get enhancement within the vestibule or the cochlea itself. So we've run this a few times, but this takes about 10 to 15 minutes to run. So it's quite time consuming. So that was the first case. Second case, Mr. Kaha, 50-year-old man, generally well and presented with sudden onset vertigo about a week ago, with a second and third shorter duration vertigo. So there was no known trigger, and the first one lasted for several hours, and he reported left worsening tinnitus, although he always had a little bit of tinnitus. He had left hearing loss, no fullness, no other neurological symptoms. Otoscopy was normal, eye movements normal, head thrust normal, and PTA showed left asymmetrical hearing loss, and the tympanic membranes were normal bilaterally. So the impression here was also Meniere's, and he was started on low salt and caffeine and Bitasec, and then we organized the MRI the following day. So same sequences were run. So you can see that this is the cystonogram sequence, and again, we see good signal within the vestibule. And this is followed by the FLAIR image. And on the left side, where he reported his symptoms, you can see that the enlargement of the endolymphatic content has increased significantly compared to the normal right side. One of the problems that we find is that it's difficult to get rid of the artifacts anteriorly within the prepontine and CP angles. And you see this even on the sequences that is done pre-contrast. And even on the pre-contrast, sometimes there are signal changes within the vestibule that we find a bit hard to account for. But definitely post-contrast, all the perilymph will be enhancing. Okay, so this one had a ratio of about 50%, so this was called as positive. So we have, this is the coronal view of the same patient. We do add the coronal views sometimes, and you can see that over here, it looks a bit bigger as well. So we have done about between 35 to 40 cases, and we did an audit with the ENT guys last year. And we used the cutoff of 50 to kind of tally between definite Meniere's, and we found that we could probably lower it to 40. So at the moment, I'm using about 40% before we call it significant. And since we have acquired the 32 channel coils, we are planning on trialing out the this study that was performed by Naganawa, and he uses the 3 sequence of MRC, PPI, and PEI, and so we touched on this earlier on. So generally, these again are the sequences that they would provide, and hopefully when we perform this on the single workstation, we'll be able to better identify the cochlear hydrops here as well, using the hydrops tools subtraction. So far, we've done just one or two, and they haven't turned out very well. So we're still collecting a few more before we run them all together. I guess that's it for NUH.
Very nice, Clement. Thank you. Julian or Mel, who wants to go next? Because I think we are running out of time. Whoever's ready.
I just have two cases. I can show them to you. Just let me try and share the screen. Hold on.
Okay, Ken. How? Me?
Just zoom on here. I can't share the screen. Somebody else is sharing at the moment.
I think should be able to now, you know. You want to try?
Now can.
Okay.
Okay. Okay, I'm just going to go through this very quickly. Basically, we haven't done many cases. We've only done about 2 or 3 ourselves because we had a lot of difficulty. We didn't have the right coils. We didn't have, and our older 3T machine couldn't, with our older 3T machine, we couldn't really get very good images. So with the Vida that we just got, we've just done a couple of cases, and the images are, the results are a bit more encouraging. We do a full pre-contrast, we do the full IAM study. So, pre and post T1, coronal and axial. We also do the cysternography as well. And then we give the contrast, and 4 hours later, we do both the 3D IR as well as the 3D flare. So for the first case, this is a 22-year-old lady. She's actually had bilateral hearing loss since young and has a left-sided profound hearing loss, right-sided moderate hearing loss. She started developing episodes of dizziness in April of 2018. These were associated with tinnitus and a prodromal syndrome. The dizziness was improved with betahistine. Clinically, EACs, external auditory canals and tympanic membranes were normal, eye movements full, no cranial nerve deficits, no nystagmus, but the clinical suspicion was that for hydrops, and an MRI was ordered. So I didn't show the cysternography, but basically this is the axial post-contrast image to prove that there is no vestibular schwannoma present. And it's important that you do this because you want to make sure that there isn't a schwannoma which may be responsible for the patient's symptoms. So I'm now showing the delayed images. On the left is your 3D flare, on the right is your 3D IR. I'm showing this because this is to show you the perilymph enhancements, which you should be seeing on the affected side. And I find that the enhancement is better demonstrated on the flare rather than the 3D real IR. I'm now showing you the images of the vestibule. Lesion is on the right, by the way. So you can see that there's dilatation of the endolymphatic space with merging of both the utricle and the saccule. Based on the Barath grading, we thought that this was going to be a Barath 1. If you're going by Bennett's grading, then it's a grade 2. The image on the right is the delayed 3D real IR, and you can see the filling defect there with a rim of enhancing perilymph. Now, the question was whether the cochlea had evidence of hydrops, and I do find that this is quite difficult to tell. On the left-hand image, you've got your 3D flare, and it looks like there is a filling defect in the cochlear turn. Looking at it and actually scrolling through on the 3D IR as well as the 3D flare, we felt that we were actually dealing with a grade 2 cochlear hydrops, both on the Barath and Bennett's classifications. What we also found was what we thought might be grade 1 hydrops on the left, but the patient is asymptomatic on the left. And this actually corresponds to what has been reported in the papers previously. I'm not sure whether you agree with this, Ling, but it certainly looked like there was a little nodule there. You can see there's a little black hole within the cochlear turn.
Yes,
I now
possibly.
go on. Okay, this one here, right there. Okay, so now we come to the second case. This was just done 2 weeks ago. 34-year-old male, no prior history of note, started having 2 episodes of right-sided tinnitus at the end of last year, had another episode of tinnitus with vertigo this year, lasting about 20 minutes. Audiometry showed a right-sided frequency, low frequency sensorineural hearing loss. MRI again ordered. Again, post-contrast axial shows no evidence of a schwannoma. Here again, we are looking at the perilymph enhancement, and the right-sided enhancement is greater compared to the left. I again feel that the enhancement was better shown. Oh, sorry. I think this is flipped. I think the images are flipped. My mistake. It should be 3D flare on the left and 3D IR on the right. Now, for the vestibule, you can see that there's a filling defect within the vestibule, and there's a rim of perilymphatic enhancement seen. Again, I feel it's better demonstrated on the 3D real IR as opposed to the flare. The flare is pretty grainy compared to the 3D real IR. And I thought this was a grade 1 vestibular hydrops based on Barrath's classification or Burnett's 2. Now, again, we had difficulty with the cochlea, but if you look at it, it looks like there is actually a continuous filling defect within the scala vestibule, within the cochlea here, right? And therefore, we felt that this was going to be a cochlear hydrops grade 2. On the unaffected side, on the left-hand side, possibly a little filling defect there, but this was a little bit less obvious as compared to the first case we saw earlier. Now, one thing that I did notice in this case, and I'm not sure whether any of you have noticed that, is that I could see that the dilated endolymphatic space was actually extending into the superior semicircular canal, or at least it looks like it. And I'm not sure how many of you have actually had that same experience. And I don't recall this actually being reported much in the papers. I don't think people have actually mentioned this much.
Hi, Julian. This is Siwei.
Yep. Yep.
So I mean, Ling and I don't know whether she remembers, but I have actually seen one case.
Okay.
So I got a feeling that some of these, right, are actually the dilated ampulla from the semicircular canal.
I suspect so, yeah.
Especially if you can see the saccule and utricle very well. And even though in radiology papers, they don't describe it, but if you look at the pathology papers, they do actually talk about it.
Exactly. So that's why I'm thinking, you know, this may be something we might want to look at if we can pull the cases together and actually put out a paper on this. I think it's worthwhile reporting. Okay, that's it for me and for my 2 cases.
Thank you, Julian. Mel, you ready to project?
Yeah, just
yeah. On SGH side, we do see dilated ampulla of the semicircular canals in the cases that we've done.
Can you see my screen?
Yes, please go ahead.
Okay, I'll just quickly go also. So
wait, your screen. I think I only saw. Sorry, we only see your name, not your screen.
Hello.
Hi, Yong, please.
Yeah, I'm still in the clinic seeing patients. I'm finishing already. I'm here.
Okay, how about now? Ken?
Yeah, I can see your screen now, Mel.
Okay, Ken. Yeah, sorry, so I just dash through. This is a 75-year-old female with long-standing on and off vertigo for many years and treated for right-sided manias. Has long-standing right profound sensorineural hearing loss and recently developed left moderate to severe sensorineural hearing loss in the last 3 months. MR was ordered for hydrops evaluation. So these are the findings first before I go through the images, so that so that everyone is on the same page. So we see increased perilymphatic enhancement of the cochlea bilaterally, as well as bilateral grade 2 cochlear endolymphatic hydrops and bilateral grade 1 BRF grade 1 vestibular hydrops. Okay, so these are the images. You can see very nice perilymphatic enhancement in basal 10 of the cochlea. And then there is also continuous dilatation of the cochlear duct that we will grade it as grade 2 cochlear hydrops on both sides actually. Yeah, and then as for the vestibular part, this, I think there is, so I mean, there's a dilated endolymphatic space that occupies more than 50% of the vestibulum, and there's still a rim of fluid around it that can be seen. So I think this will go for BRF 1 on the left. On the right, also, I think endolymphatic space is probably dilated by more than 50% of vestibulum as well. So yeah, so overall findings, as I said earlier on, I think in this case, it was a bit complicated because she does have bilateral severe sensory neural hearing loss, which can have endolymphatic hydrops. And also she's got previously treated for right-sided manias. Move on to the second case. 66-year-old, admitted in 2020 in July for 2 episodes of vertigo, each lasting about 2 hours, query left manias. Also has a long-standing history of left-sided hearing loss since 1980 for loud noise at work. And then there's also a right ski slope presbycusis hearing loss pattern as well on audiometry. I just summarized it because I don't want to go too much into detail. Caloric response, basically in general, the left side warm response is lower compared to the others seen here. And the heat impulse test, basically this is the left. I just move this away. So the top is left hand side, right hand side, lateral, anterior, and posterior. Okay, so we can actually see that the left hand side, the values are lower compared to the right, and it's true for mainly the left anterior, a bit on the left lateral, 0.75. I think some people use cutoff at 0.75. And so all this actually indicate a left-sided peripheral vestibular hypofunction. And interestingly, on repeat this is 7th of July, so on repeat on 20th of July, it actually improved. Sorry, I forgot to say also there's saccadic eye movements on the left, which suggests the peripheral vestibulopathy on the left. Yeah, so actually on repeat imaging, on repeat heat impulse test on the 20th of July, we actually see some recovery of the left-sided function. So MR findings, again, I will just say the findings so that everyone can agree on the findings later. There's grade 1. We think that there is left-sided grade 1 cochlear hydrops and grade 1 BRF on the left, definitely. The right, there was no cochlear hydrops and probable right grade 1 with a series of more than 1. Okay, so you can see some dilatation of the cochlear duct on the left. I don't think this is normal. It's a bit dilated on the left, so I think this will go for at least cochlear grade 1. For the vestibule, also I think the endolymphatic space is dilated more than 50% on the vestibulum with a nice rim still appreciable. So this will go for BRF 1 as well on the left. The right, I think the S and the U, I think the S is a tad bigger than the U, the utricle at the back. You can argue that the series ratio is then more than 1. So this can still go for series 1 on the right with Mao. Yeah. So the clinical diagnosis was quite consistent with left manias with left hypofunction and acute hydrops changes. I'm actually done with my cases, Dr. Chan.
Thank you, Mel.
Yeah.
We have tried to show cases from different places. I probably there are questions from the audience here. It is important to for the otologists, if you hope to start the service in the hospital, in the clinic, the imaging clinic that you are with, talk to the radiologists, help the radiologists out by sending them to begin with the most severe unilateral Meniere's case. It helps because it's not easy looking at all these tiny anatomy and trying to get used to seeing it. Working together with the radiographers and the application specialists from the vendor, it's also very important. Of course, we are lucky to have MR physicists as well for assistance. Has anybody got any questions that we can all pitch in to help out? The Meniere's imaging, it was made possible in SGH because Yuming, basically Yuming helped a lot by sending very obvious cases in the beginning for us so that we get used to seeing it. Learning the anatomy of the intricate inner ear structures is actually quite critical.
Yan Rong here. Hello, can you hear me?
Yes, hi.
Yeah, Yan Rong here from CGH. I just want to ask a question about the 16 versus 32 channel coils. What does SGH use, and is there, or NUH experience, is there any difference with, is there a lot of difference between the 16 and 32 channel coils?
So in SGH, we have been using the 32 channel head coil. We understand the signal to noise is much better. I think because, as you saw Septian showed on his slides, at the periphery, the signal is better on the periphery for the 32 channel head coil. We believe that may be a reason why we had it easier, so to speak, to get this imaging going for Meniere's. I don't know. I think we will need to hear from Clement in future when he does.
So we've only just started the 32. I mean, so far we haven't had definite cases, so it's hard to really comment because we've only seen probables. So have to give it a bit more time, I think, for us.
Yeah.
For Tock Seng, we use the 16 channel head coil. Frankly, I think the images would definitely be better with 32 channel. Having seen the cases done at SGH, but I am quite surprised that we've been able to get what we've got for the two cases that I showed you, even with the 16 channel. And I'm not sure whether that's a function of the magnet being a bit more powerful now because we're using the VIDA.
Yeah, yes, probably. Also, in terms of protocol, like Julian, he does the flare and also the inversion recovery, the real inversion recovery. For us in SGH, we are quite tight on time. So of course, if we have the luxury of doing more sequences, we'll love to, but because, like one sequence takes up 15 minutes, the real IR, 3D IR. So like we cut away the flare, the 3D flare, delayed post-contrast, just so that we can cut down on time. The other maybe interesting question that has arose since we started service is that occasionally we've got patients where it is ordered for imaging, but even in the usual diagnostic, on the intrinsic T1, we already see high signal in the inner ear structures, and then post-contrast immediate, you already see enhancement, mild, probably a case of hemorrhagic labyrinthitis, and even ordered for Meniere's imaging. The question is, should we abort it at that point, or do we continue? Do we save the patient some cost by not doing the delayed? Do we train our radiographers to be able to recognize that? Or do we have the time as radiologists to go in and out of the room to protocol that? So those are some of the points of discussion that some of the issues that we've come across in our imaging. Would there be any other comments from the clinicians? I understand that I would think if I were a patient of Meniere's imaging, even though some people feel that it's not important to document the endolymphatic eye drops, I think for myself, if I were a patient, I think I'll be very gratified to know, to be able to see structural abnormality and know that I'm not so-called malingering, because I think vertigo is sometimes not easy to objectively quantify.
Hi, I'm King Chun. I have a question. There are various classification systems, right? So in terms of reporting, is there a particular system that we lean to or that the clinicians rely on, or is again based on different styles and practice?
Can I take this, Ling? Frankly, I think it is important for the surgeons and the radiologists to sit down and decide on which system they want to use. But in the meantime, what we're doing here in Tock Seng is that we state specifically which classification system we're using, so that there's an easy reference for the clinicians when they want to look it up. But I personally feel it is best that both departments decide what common language they want to speak. Ling, how do you feel?
Yeah, I think as Siwei has shared, the latest evolution of the grading system is the Bernard's one that came out last year. I thought that was actually quite a good grading system, the 4-grade system with the perilimb enhancement assessment.
Yes, and they even have a very good workflow, because in the Bernard system, the moment you say there's perilimb enhancement, it's deemed Meniere's already.
To be honest, of course, I think some clinicians may feel like, I don't know, I mean, what is the clinical impact, whether you call it grade 1 or grade 2, you know, does it make a difference to the clinicians? I don't know. Do we have any more clinicians in the audience left to help us with that input? I think most of might have gone back to work already.
Yeah, Ling, sorry, I'll just make a comment perhaps.
Okay,
That's here from ENT. Because Mr. Chan is really the boss in terms of vestibular otology work. I think he's set up in clinic. I would say I feel how an otologist can help is really to try and get an accurate clinical presentation and audiological guidance in the diagnosis of Meniere's. In terms of radiological in terms of the radiological measurements, I guess you guys are really the experts, and whether there's any clinical impact, as what you have mentioned, I do think it's very useful for the patient to know if their radiology supports the diagnosis of Meniere's. And in terms of the grading severity, I guess it doesn't make so much of a difference in terms of how you manage the patient. Yeah, so that's my 2 cents worth.
Thank you.
Thanks.
But maybe as Siwei also mentioned in her slides, if the endolymphatic eye drops is of a more severe degree, then you know for certain that is really probably pathological. Whereas if it's a mild, like a grade 1 only, it's a plus minus, because false positive have been found in asymptomatic years as well. But I guess I think more studies are needed to see whether the minor findings in the asymptomatic years, whether longitudinally over time they might worsen and become a full-fledged severe grade endolymphatic eye drops. Okay. Are there any other questions from anybody else? If not, we will be ending the session today. Thank you all so much for all joining in. Do go discuss with amongst yourselves, the clinicians and the radiologists, and we hope that across Singapore there'll be more imaging on Meniere's. Yeah, we hope you found this webinar helpful. We'll be happy to take questions on email, or if you have any questions that we can help with. Thank you everyone for zooming in. Thank you and have a great day. Bye-bye. Thank you.